Hello, fellow classmates and faculty. My name is Leslie N. Martin, and today I am going to present my DNP project, Effects of Rounding on Fall Prevention in Adults Living in Assisted Living Facilities in Partial Fulfillment of my Maryville Doctoral Nursing Degree. These are my committee members. Dr. Jennifer Hopner, my chair, Dr. Lisa Stewart, the second reader, and Dr. Myla Carpenter, the medical director at the facility. The purpose of this project was to evaluate the effects of rounding purposefully to prevent falls in older adults living in aged care institutions, specifically assisted living facilities. Why? Well, believe it or not, falls are a persistent problem for older adults. Older adults are people aged 65 years and more. They are prone to falls because of conditions that affect their gait, visions, or neurological diseases such as Parkinson's, multiple sclerosis, dementia, or they may be taking medicines to manage diseases such as diabetes, hypertension, pain, or mental illness, as well as environmental factors such as loose rugs, poor lighting, and clutter. They all play a part. Now, the CDC reports that every year at least 36 million adults have falls, with 1 in 5 being serious enough to cause significant harm. And older adults, not just regular adults, older. 58.1% suffer an unintentional harm, such as hip fractures and other broken bones, as well as traumatic brain injury. Worse yet, 30% die unintentionally from falls. Not only does falls have disastrous physiological effects, but also can cause psychological ill effects as well. After having a fall, for instance, whether significant or insignificant, many individuals suffer from depression, anxiety, and fear of falling, further increasing the risk for falls. Did you know that one of the biggest risks of falling is having fallen before? This worrisome problem was encountered at the facility where the project was conducted. In fact, I would see at least 2 older adults for evaluation at that facility after having a fall, despite the facility having a fall prevention protocol. Needless to say, I saw the significant need for an effective fall prevention program. Something had to be done so our residents could lead better quality lives fall-free. The aim was to decrease falls by at least 50%. Now, what exactly is a fall? A fall is defined by the World Health Organization as a sudden, unintentional descent that results in the person coming to rest on a lower floor surface unexpectedly. Interestingly, older adults with complex health conditions are opting to live in assisted living facilities when they cannot take care of themselves. These assisted living facilities are evolving to care for patients that are more ill than before, as there is a push to allow these seniors to age in place. This explosion of aging in place is creating new challenges to keeping this adult population safe from falling and leading a good quality life. The cost of falls can be expensive. According to the CDC, in 2023, the average medical cost of non-fatal injuries from falls in older adults equal $50 billion. That's non-fatal. And another $754 billion on fatal, of which, get this, Medicare and Medicaid shoulders 2/3 of this expenditure. Considering that life expectancy is extending, imagine the significant impact that unmanaged falls has on the healthcare system. Imagine how costly it could be. Additionally, nursing is charged with executing quality and safe healthcare. Nurses are in the right place to help maintain safe quality care by stopping these injury-producing falls. Decreasing falls would be beneficial for all involved. This demography, the organization, as well as on a local and national level. the costs associated with falls would be driven down and the potential for lawsuits and increased morbidity and mortality would be lessened. And most importantly, our seniors would be protected from falls. In order to execute this project, a review of the literature was done to determine the best evidence on fall prevention in institutional settings. A thorough search was completed using CINAHL, PubMed, Medline, Complete, Ovid, and Cochrane databases, applying filters English language, peer-reviewed, full text, and articles from 2012 onwards. With keywords adult, older than 65, rounding, hourly rounding, preventing falls, reduced falls, and aged institutions to narrow the search to relevant studies only. There were several common themes that emerged that we will discuss further. The themes included purposeful rounding, which is the act of assessing and managing patients' needs preemptively on a timed schedule. The goal there was to address the fall-producing factors early enough to avoid falls using 4 Ps. The patient needs for toileting, pain management, personal possessions, and body positioning was assessed every 1 to 2 hours routinely to maintain patient safety. And rounding was demonstrated in those studies to prevent falls by 50%. Settings is another theme, and it showed that varied settings utilized the rounding process and was successful to reduce falls. Acute care settings such as in the hospitals, in the med-surg, ICU, ER, and other specialties, as well as chronic age settings such as nursing homes, subacute rehabs, and assisted living facilities, where this project will be focused. And all of them, again, were successful at reducing falls. Staffing mix was another theme that surfaced, showing that all levels of nursing was used, from nursing managers to the nursing assistants, proving that rounding can be done by any staff member. Evidence surfaced suggesting that increasing nurse-patient interactions had an inverse reduction with falls. Increased time equal reduced falls. Successful implementation was another key theme. Studies revealed the greater the acceptance and involvement of the stakeholders, the greater the success of executing the rounding protocol. You needed high buy-in and support from all stakeholders. Outcomes, which is the main outcome was reduced falls, was evident, as well as some other. Call bell usage had been reduced. There was a decrease in loss of personal items such as hearing aids and glasses. Pressure sores had been reduced. Increased patient satisfaction and increased patient-provider communication, as there was high visibility of the staff and interaction between the staff and the patient. In general, quality of care increased as the nurses became more cognizant of the patient's risk factors and needs. Fall prevention in an aged care setting may be challenging. The COVID pandemic may have added additional challenges, as there was high nursing turnover leading to staff shortage, which could negatively impact the remaining staff and cause change resistance. The remaining staff may resist change, as adding any new task may cause them to feel overburdened and overstretched. For a successful implementation of the rounding process, the staff would need to see the benefits for both themselves and the patient. So the best suited framework needed to implement and execute the project was determined to be John Cotter's change theory. This is a modern-day change process for implementing successful change initiatives in organizations that are designed to help overcome potential barriers and challenges. There are 8 steps. So the first step includes establishing a sense of urgency for why that change is needed. In this case, discussions were held on falls, injuries, and costs to the organizations and patients. The second step involved getting buy-in from key stakeholders, and this is through ongoing discussions about the problem and why you need to have change. The third step is where the vision of the benefit for the organization, nursing staff, and patients are created, showing that reduced falls equal less injuries, workload, and financial costs. The fourth step is to communicate that vision by providing clear visions with a goal. The fifth step is educating and training to assist removal of potential barriers. The sixth is to keep a continuous process feedback. The seventh is to share success stories to help build the change. And the last step is, after establishing that change, committing to maintaining that change, is institutionalizing that new and learning approach to produce permanent change. After buy-in was secured, the methodology of the project ensued. So the project's methodology is, this project was a quantitative, quasi-experimental design using a retrospective chart review, collecting data to compare the fall rates before and after implementation of the rounding process. The project was completed in a 220-bed assisted living facility in the Northeast region of the U.S. The Director of Nursing supplied the monthly fall incidence report, which is a report of documented falls, the timing, location, and injury, if any, that was recorded by the staff at the time of the incident. Prior to the implementation, all nursing staff, which included the RNs, LPNs, CNA, CMA, anyone that was involved in patient care, would participate or participated in a 15-minute training and competency evaluation sessions. These sessions taught and demonstrated how to successfully round using the 4 P's, what they were. And they were party, pain, position, and possession. Tool 3B, which was retrieved from the Agency for Healthcare Research and Quality, was adapted for the assisted living settings. It was used as action guidelines. Rounding log was devised to capture the staff's compliance, and the project was to take place from October 1st to the 31st. It was divided into 2 parts: the pre-intervention for the first 3 months and the post-intervention for the last. The sample was that of convenience, and they were the 220 residents that resided at the facility during the course of the project. The participants were neither engaged or recruited. The inclusion criteria was the participants had to be over 65 years, all genders, and living in the facility for the period of the data collection. However, they could not be bedridden, which was the only exclusion criteria. All necessary steps were taken to maintain HIPAA privacy. Firstly, the data collected was limited to a minimum data set, which was coded numerically to prevent any breach of confidentiality. Secondly, the data collection sheet was stored on a password-protected computer in the Scholars Locked office, mine, and accessible to me only. And at the end of the data collection and analysis period, the monthly reports were returned to the Director of Nursing for appropriate disposal. So the sample participants were mostly Caucasian. The ages varied from 69 to 104 years. They were mostly females. As you can see, the ratio was about 61% versus 39% males. There were different degrees of dementia and other medical conditions such as hypertension, heart failure, heart disease, and diabetes, and they all lived in the facility from the period of the project. So these are some of the results. Graph 1 shows the fall rate incident per individual, The first month there were 70 falls in the blue area here, and after implementing rounding, there were 67 falls with just a 3% difference. In graph number 2, these were all individual falls, and they were by the months. And as you can see here, there were not much difference. Some months you had more falls, some months you had less falls, but there was no consistency. We have some more graphs coming up. And here we have the to your left, you have a pie chart that shows where the falls were mostly located. And as you can see, bedroom won by 54%, with 42% in the bathroom, a second close, and only 4% in other areas. The fall timing showed that they predominantly happened to fall during the periods of 12 a.m. to 6 a.m. and sort of evenly almost dispersed between the 7 a to 3 p.m. shift and the 4 p.m. to 11 p.m. shift. So data was analyzed, then comes the data process, and it was analyzed using descriptive and correlative statistics. Power analysis was done to show how much charts would be needed to have an effect, and it suggested 154 charts. Chi-square was used to determine a relationship, which it did show a relationship between falls and rounding purposefully. However, the effect size was small, with a pi of 0.290. The z-test, which shows the difference of two proportions, did not demonstrate any difference in the fall rate after the rounding implementation. In fact, the significant level was p 0.6213, which was greater than the significant level of p is equal to or less than 0.05. So this meant that the null hypothesis was rejected, as there was no difference. So with all projects, there may be some limitations, barriers, and facilitators. So the limitations are possible incomplete or unrecorded information, maybe some missing data. Then the rounding log actually in this case was discontinued within month 2. Tool 3B was adapted for this setting. However, was made for hospital settings. And again, we had inconsistent rounding hours. The barriers were the resources, which were the staff. They were short-staffed pretty much every day, which left the remaining staff feeling overworked and unable to complete the rounding as scheduled because of having the additional residents. As time progressed, there was some loss of buy-in from some of the stakeholders, in particularly the assistant director of nursing, and there were some unit managers as well, which may have affected the project. Facilitators for this project was the director of nursing, who really had great enthusiasm for success, and she facilitated a lot of roundtable discussions to promote the program or the project. And the nurse educator was very instrumental because she helped educate the staff. She performed the competency evaluations, and she would even round on the floor frequently from time to time to gather feedback and to reinforce the benefits and how to execute the rounding process. So what were the findings? The project found that rounding purposefully was ineffective in reducing falls in this setting. There was an insignificant difference with a small power effect. The total number of falls did not decrease. However, there was a modest decrease in falls per participant. Result findings did not produce the desired goal of a 50% decrease in falls. Only a 1% decrease was noted. This was inconsistent with other studies that had about 50%. Falls occurred more in the bathroom and bedroom and during the nighttime, and also were unevenly distributed between females and males, with females falling more. Interpretation, plausible reason for the differences between the expected outcome versus the observed outcome would be: 1, the inconsistent support from leadership; As stated earlier, the buy-in dwindled over time, which could have caused challenges with the staff and the process. Two, other studies used an hourly process, whereas this project had a 2 hours in the day and 3 hours at nighttime as it was adjusted for the chronic care setting. Some studies that had a better outcome did have a smaller sample size. One study had 26 participants and another 30. Also, some studies discussed that their organizations were better staffed. Notably, in this project, two of the participants had an increase in falls after rounding was implemented, suggesting that differing levels of patient acuity may need a more tailored approach, as some patients require more care or increased rounding frequency. Evidence-based rounding was unsupported in this project as a fall preventative method. Therefore, cannot be sustained at the facility or generalized to other organizations of similar settings. So the recommendations are removing barriers, which is beneficial for effective management of the change process. The facility was inadequately staffed, that's a barrier, but due to the project's scope, it's something we can do much about. However, the loss of buy-in is something we may be able to change and which would promote and sustain the process. So recommendations include repeating the pilot study using a different framework, the Plan, Do, Study, Act cycle, as this framework is better suited for complex environments when introducing quality improvement programs. The PDSA cycle carries out the tests on a smaller scale to learn about any problems and unexpected observations then they make changes to the process continuously in a cycle until they obtain the best outcome. Additionally, prolonging the study. One study by Laviolette in 2020 in a long-term care setting revealed that rounding became more successful in fall prevention the longer the process continued. So to determine real efficacy in this setting, time frame should be prolonged. This study was just 12 weeks, so something longer would maybe benefit. So implications for practice. Though there was an insignificant statistical difference, making this project unable to substantiate rounding to reduce falls remain a significant problem in this population. It causes fractures, brain bleeds, and other health sequelae such as anxiety, fear, and depression. Though this project cannot endorse rounding purposefully, future research is needed on effective strategies in this population to mitigate falls. Falls are a well-known problem for older adults, which need to be addressed on all levels, local, state, and national level for policy making. So in order to influence health policy, we need to have an effective strategy that has been proven superb in fall reduction. And as for quality and safety, the Institute of Medicine considers patient safety interchangeable with quality healthcare. So it is paramount to develop a robust fall prevention approach that can keep our seniors safe to lead normal lives that are free from unnecessary injury. So in conclusion, the study set out to translate the project set out to translate best practices in fall prevention for older adults that live in a chronic care facility. The goal was to increase the quality and safety of healthcare. Falls lead to injury, complications of pain, reduced mobility, and a general decrease in quality of life. If falls continue to persist in this population, not only do they suffer consequences, but so does the healthcare industry, as injuries from falls are costly. Rounding purposefully has been demonstrated in many settings to decrease falls, but this project could not demonstrate the efficacy in this population. Future research should focus on using rounding together with other methods to improve fall rates in this setting and use a different framework approach such as the PDSA cycle. These are my references. If you have any questions or comments, please feel free to contact me via email at lmartin1@live.maryville.edu. Thank you for your time and enjoy the rest of your day.